X, and there is a complex pathway involved during micturations. It ranges from brain to the bladder, and the coordination is achieved by central nervous system through pontine micturation center. The cortical micturation center is the highest center. It's located in the paracentral lobule in the median aspect of the frontoparietal cortex. Its function is inhibitory to the pontine micturation center. And when it's appropriate, it initiates the voluntary micturation. Whenever there's a dysfunction of the cortical micturation center, there's loss of social control of bladder. And since there is the loss of inhibition is lost, so you may see some overactive bladder functions. The bladder control or the cortical control is part of the social training, and kids usually experience it at age 2 to 4 years. The pontine micturation center or Barrington nucleus, it has two parts. The lateral region function as a continence and storage of urine. When it stimulates, it results contraction of the sphincter, and the medial region, which function as a micturation, when it stimulates, it causes a relaxation of the sphincter and at the same time rising the detrusor pressure. The way I remember it is basically the lateral I consider lateral as a sphincter around the urethra, and the medial is middle part, which is the urine, which is for the urination. So at local spinal level, bladder is innervated by the sympathetic, parasympathetic, pudendal nerves. You guys all know that very well. Sympathetic is the main function of sympathetic nerve is inhibitory to the parasympathetic ganglions, and its main function is storage. Parasympathetic innervation or stimulation causes micturation and voiding. And the pudendal nerve is a somatic nerve which innervates the external sphincter. So this is a typical micturation of a normal adult. You can see that in this diagram that when you fill bladder, the upper part is the bladder pressure, lower part is the EMG or electromyography tracing. Bladder fills typically with no rise in pressure, but you can see that there is a rise in this striated or the EMG activity, indicating that as the bladder fills, there is more contraction of the external sphincter. And when there is a voluntary void, the bladder pressure goes up and the sphincter relaxes completely. And when you stop there is a stoppage of the urination, then the bladder pressure goes down and the striated fraction goes up. So this is a typical normal voiding pattern. You can see different pathologies and different clinical features with lesion at different levels in the brain and this nervous system. If there is a lesion of the suprapontine, you may see overactive bladder, but the sphincter should act normal. In history, these patients usually presents with the storage symptoms. On ultrasound, you may see small volumes and insignificant PVR since sphincter is functioning normally. Urodynamics, you may see some detrusor overactivity. Sorry for that. Whenever there's a lesion at the spinal level, especially above the T12, you may see overactive bladder as well as the overactive sphincter. And this is the worst form of the neurogenic bladder. You may see patients with both storage and voiding symptoms. There's high PVR as well as there may be a small volumes. In urodynamics, typically you would see a detrusor overactivity and detrusor sphincter dyssynergia. And we will briefly discuss those later, how those findings you will see on your dynamics test. And if there's a lesion at the lower level, especially at the sacrum and the infrasacral lesion, the bladder is underactive. and the sphincter may act normally or it may be underactive as well. So typically patient presents with the voiding symptoms. Patient may be have overflow incontinence or have difficulty in passing urine. Ultrasound will show high residual urine, and urodynamics typically shows hypocontractile or acontractile bladder or detrusor. So you can interrupt me anytime when you have any question, or you can raise hands. I don't know how that would work, or you can send me a question in chat. So at the end we can answer those. So the one broad classification of the bladder dysfunction is either neurogenic bladder or non-neurogenic bladder, but it behaves as neurogenic bladder. So neurogenic bladder refers to a dysfunction of the urinary bladder due to lesion at any level in the nervous system. Non-neurogenic bladder dysfunctions, there is no obvious neurological cause, but it behaves as a neurogenic bladder. And recently in International Continence Society, they grouped them together all in daytime lower urinary tract symptoms. Incidence is very variable, and it also depends on how do you define it. In one of the study which was done in preschool kids, a population-based study, and they enrolled almost 15,000 kids. All of them were preschool age, and sorry, not preschool, but early in school. And then they found that the incidence was almost 20%. And they found that almost 19% of kids, they had an incidence of incontinence in the last 6 months, and that's what they defined as daytime lower urinary tract symptoms. Classification is also based on the level of lesion, and also depending on the symptom, if the patient has storage symptoms or voiding symptoms. So you can, especially in kids, I know there are a lot of other conditions which contributes to the neurogenic bladder in adults, but in kids, myelodysplasia is one of the common conditions that cause neurogenic bladder. You may see meningomyelocele, myelomeningocele, and lipomeningocele. You may not see any obvious defect. It's called spina bifida occulta, or if there is a meningomyelocele, it may be on the anterior aspect of the spinal cord, so you won't be able to see it. So if it is not obvious, it's spina bifida occulta, but you may see the same severity or even worse severe symptoms in spina bifida occulta. It doesn't mean that they present with less lower urinary tract symptoms or less neurogenic bladder symptoms. The other conditions are the sacral agenesis. It's easily diagnosed on X-ray. You may see that the sacrum is absent, and it's typical sacral agenesis, which leads to neurogenic bladder. Anorectal malformation is another common condition. It ranges from just imperforated anus to cloacal malformation or cloacal extrophy. And again, at last there are, maybe trauma to the spine or transverse myelitis in kids. The evaluation starts with the history, and we all know, it needs a comprehensive medical history. We especially emphasize on the incidence of the lower urinary tract infections, if they were febrile or afebrile, and how frequent those UTIs are. And the other condition which is commonly associated with the neurogenic bladder is the incontinence, and how severe it is, what time it happens, how long is the dry time, if they have taken any medication before, if they have tried anything else, if they have tried like time voiding, double voiding, all those sorts of things. And again, how is the voiding pattern? If they have ever maintained a voiding diary or catheter diary, that's also very, very helpful in assessment of those kids. An assessment of the neurological functions, if there is any numbness, weakness in the lower limbs, if there is any back pain. Constipation is very, very important, and usually it is not evaluated in majority of patients, unfortunately, but it's very important to assess the constipations. We know that colon and bladder, they are neighbors. But sometimes colon is not a friendly neighbor, actually. They share a small space. in the bony pelvis. And when the rectum or the colon is full of stool, it causes pressure on the bladder and it compromises the bladder capacity. Similarly, if the hard stool is lower in the rectum, it can push on the urethra, and especially in adult age group, if there's an enlarged prostate, it creates an angulation. It's hard to pee. So especially in kids, if someone presents with voiding as well as the bowel dysfunction, or we call it bladder bowel dysfunctions, if you treat the bowel first, majority of those kids, they're well with bladder, and they spontaneously resolves as long as you take care of the constipations on them. On physical examinations, again, complete physical examination is required in those kids, but especially we assess them for the ambulatory status, complete genital examination, and examination of the spine and the lower extremities. Especially the emphasis on the back. See if you can see any hair tuft, if you can see any AV malformation, if you can see just a discoloration at that level. Sometimes you may see an obvious defect there. Gluteal line or gluteal cleft, any asymmetry here is also indicative of there may be a spina bifida occulta, and you can assess them further. And further to the laboratory evaluation, urinalysis is the first test we do. We look for any signs of infections, and we do urine culture, make sure that they don't have UTI. Voiding diary is very, very important. And you can assess a lot of things from the voiding diary. The kids may present with a spectrum of conditions. You can see how much fluid the kid is taking, what kind of fluid, are there any bladder irritants, the amount of fluid as well as the timing of the fluid is also important. Sometimes kids presents with nocturnal enuresis, and you will find that they are just drinking water at night time or in the evening. And again, the other important parameters you can see through voiding diary is the functional capacity of the bladder, and that's very important. That actually guide you regarding further investigation of those kids. Uroflowmetry is a very simple test. Sometimes it's challenging in kids, but if you can get it, it gives you a lot of information. If you look at the pattern, if it is a tower pattern, usually it's an overactive bladder. If you see a staccato pattern, it's because of the detrusor sphincter dyssynergia. It is a mild form, and in more severe form, there you see some interrupted flow. In plateau is usually if there is any physical or anatomical obstruction, if there's any urethral meatus, or if there's any stricture or valves. Usually they present with a plateau. And those uroflowmetry can be coupled with the electromyography. It's a simple thing to put just some electrodes in the perineal area, and you can assess the external sphincter functions while the patient is voiding. In the radiological examinations, ultrasound is readily available everywhere. There is no radiation involved. And you can get a lot of information from the ultrasounds. You can see the collecting system dilatations. You can see the corticomedullary differentiations. You look for scarring in the kidneys, and you can assess the bladder volumes and post-void residue, and all are very important information in assessing those kids. So here you can see some pictures of the normal kidney. You can see non-hydronephrotic kidney. You can see parapelvic fat. There is no hydronephrosis here. You can see that the pericardial system is dilated, and loss of the paranephric peripelvic fat. Similarly, you can see a normal bladder here with normal wall thickness, and the abnormal bladder would look like something like this, where you see a lot of trabeculations, diverticular formation, and it's a thick walled bladder. I don't see any distal uretary dilatation here in this case. VCG is the next step. If you see there is abnormal ultrasound findings, and you look for the contour of the bladder, if it is a smooth wall, if there's a trabeculations, you can assess bladder neck with VCUG, and you can assess if the bladder neck is open or closed. If the bladder neck is open, is it open right away from the beginning of the study, or is it opened up later on? And the vesico-ureteric reflux, again, is it something happens right away with filling of the bladder, or it's something happened late in the filling, which guide you actually sometimes, how is the safe, how safe are the volumes for the VUR. And again, this VCUG can be combined with the urodynamics, especially if there is a VUR. It's a cornerstone of the evaluation of the patients with neurogenic bladder. It determines bladder pressure during filling and emptying. It helps identify a patient at risk for upper tract deteriorations. Although some studies contradict it, but majority of studies, they favor that the urodynamic studies, they predict the long-term outcome of the patients with neurogenic bladder. Despite its critical value in evaluation of these kids, it's a snapshot in a point of time. So what you do, you may need to repeat those studies, especially if you have done any intervention. You can repeat those studies and see how much improvement has happened, or if there's any deterioration in the findings. So how do we do a urodynamics test? Normal saline or fluid is attached. It's typically a dual lumen catheter. The one is the transducer, the other one is the channel for the filling. The other catheter is inserted either in the vagina or the rectum to determine the bladder pressure. And I'm sure you guys already know that once we detect the abdominal pressure from the bladder pressure to know the detrusor pressure. So with urodynamic parameter, you can see the bladder capacity, bladder compliance, how is detrusor is acting, is it overactive or underactive. Similarly, you can assess the sphincter function as well. Is it acting synergetically or non-synergetically? So what is a normal bladder capacity? In adults, it's a fixed value. In kids, it's different. And unfortunately, you will have to remember this formula. For age less than 2 years, you multiply weight with 7, and you can get a capacity in mLs. For age more than 2 years, you add 2 to age in years and multiply by 30. And it gives you the expected capacity of the bladder. Recently, the AUA changed the formula. They just add 1. So if you say 1 or 2, I think both would be fine. So what is the rate of the bladder filling? I know in adults, you usually fill at 50 ml per minute. In kids, we determine them by the expected edge capacity, and we start with the 10% of the expected volume. Suppose the volume, the expected capacity of the kid is 200 ml, so you can fill with 20 ml per minute. Sorry, it's a typo. The other thing is the voiding diary can sometimes give you better idea, because the patient may have a neurogenic bladder, patient has a neurogenic bladder, and the capacity or may not be that what is expected. So if the expected capacity or if the capacity or the functional volumes are less, you can even lower the filling rate to avoid provoking contractions. So this is a typical pattern of a stable detrusor. This is an electromyogram activity. You see some contractions, especially if you ask the patient to cough or sneeze. The vesical pressure, abdominal pressure, and detrusor pressure. So here you can see that with the filling of the bladder, it remains low, and there is no detrusor or bladder or detrusor overactivity. with the detrusor overactivity, you can see that you see uh, contractions, and those detrusor contractions at least rises the bladder pressure more than 15 centimeter of water. If it is less than that, still we use this value in adults as well. If it is less than that, they are not called the detrusor overactivity. Maybe a normal, finding a normal response of the bladder. This is a kid with a 3-year-old kid with the C7 spinal cord injury. So the expected capacity for a 3-year-old boy would be around 150 cc. And here you can see that even with the start filling, there is a strong detrusor contractions, and then it subsides. And the detrusor pressures went up to 103, even at 45 ml, and at 60, patients started leaking. So this is a pattern you see in spinal cord injury, high detrusor pressure, and small capacity bladder. So a compliant bladder is a bladder who accommodates urine without rising the pressure. Its delta is a change in the bladder pressures per change in the volumes, but it's delta V divided by delta pressure. So highly compliant bladder means it accommodates volumes at safe pressure, and it's safe for the kidney to drain under low pressure. A non-compliant bladder is the one where you can see that the bladder pressure start rising with filling bladder. And here you can see that it reaches up to the 40 here at about 120 ml. And at this point, it's considered not safe for the kidney drainage. And we will discuss one study, that hallmark study, which was done in 1980s, what it showed. Similarly, one of the urodynamic features of the detrusor sphincter dyssynergia, you can see that this is sphincter activity and detrusor contractions. You can see that detrusors contracted, then there is a simultaneous contraction of and there is a simultaneous sphincter activity as well. That's typical of the detrusor sphincter dyssynergia. So that was the hallmark study, which was done in 1980 by the Wise. They followed 42 patients for 7 years. So those patients who had a detrusor leak point pressure of less than 40 centimeter of water, they found that there was ureteral dilatations only in 10% of kids, and there was no VUR subsequently. Those patients who had a detrusor leak point pressure of more than 40 centimeter of water, ureteral dilatations occurred in 81% of kids, and the VUR in 68%. So I'm sure you guys know what is detrusor leak point pressure. Is the detrusor pressure at which there's a urine leakage. It's not by the abdominal pressure, it's not by the Valsalva, it's a pure detrusor contractions which leads to incontinence, and that's called detrusor leak point pressure. So in terms of management, what are your goals? And the goals are, there are 3 basic goals when you manage those kids with neurogenic bladder. You want to preserve the renal functions, you want to minimize the infections risk in these kids, and achieve continence. The first 2 are very important. Continence, sometimes these kids, they are incontinent since childhood. It may not be very important for them. And you know, in clinical practice, you see a lot of patients who are not bothered by the incontinence, and they want, as long as their upper tract is stable and they are free of infections, they are happy. For some kids, just a drop of urine is very bothersome for the patient and for the family, and then you would have to do something for them. So typically, the management of the daytime lower urinary tract syndrome or non-neurogenic bladder, it starts with the behavior modifications. It's a long discussion with family and the patients. You need to educate them. What is normal voiding patterns? What are the deviations from the normal patterns? and especially, you know, after getting all the warding diaries and the investigations, standardization of the fluid intake is very important in those kids because there may be abnormal um, drinking habits. Bowel management is very important in those kids. You want to make sure that, you know, they are not constipated. Time voiding, sometimes double voiding also helps. And also sometimes, you know, just educate about the response to urgency, and, you know, avoid, and sometimes, you know, just avoid holding maneuvers. It depends on what you are dealing with actually. Biofeedback is very important. There are different ways to do it. It's again is a big topic. But if you do this behavioral modification correctly and able to do that, approximately 80% of children's benefits from these interventions. I know some of those kids, they already have some behavioral issues. Sometimes it's hard and challenging to do, to implement those behavioral modifications. But again, it's worth to try. And again, management of the neurogenic bladder dysfunctions. And then there are, you know, the strategies you can adopt is the observation, intermittent catheterizations, pharmacotherapy, minimally invasive options, and the surgery. And the indications for these strategies are different, so we will discuss them each one by one. So is observation alone is reasonable? Yes, for some kids. If the patient is voiding with good detrusor functions and there is minimal post-void residue and the upper tract is stable, there is low detrusor leak point pressures and there is no evidence of dyssynergia, you can observe them and they do well. What about the intermittent catheterizations alone? Yes, children who do not empty their bladder, and you want to avoid the complications of the chronic retentions. These kids, they usually have good bladder capacity, the bladder is compliant, and they have high leak point pressures. So how frequently do you do that? It also depends on the indications, for what indications you are doing it. Is it just for the continence, or if there's a medical reasons to do that? And also neurodynamics findings and the urine output also plays an important role. So we have to teach them what is the good method of intermittent catheterizations. Patient needs to completely empty their bladder because the bladder is different than heart. It needs rest. If the bladder is full all the time or partially full all the time, it's not good. It's not good for the bladder health. And some people, they advocate that it's easier if you start the intermittent catheterization earlier in life. Because it becomes a norm, it becomes norm for the family, for the patients, and it's easier to continue it later on. We encourage our patients to do it, we engage them, and when they mature and if they can do themselves, we usually transfer the responsibility. So one of the challenging things, and usually it's a very clinical scenario, that you do a urine analysis in these kids who are either doing CIC, and they found that it's an abnormal urine analysis. So is it abnormal urine analysis means anything? No. These patients with the catheterization, you're introducing foreign body. Their urine analysis may look horrible. But to correctly diagnose, you always need a urine culture in these patients. The other scenario is, do you need to treat all these patients if they have a UTI or positive urine culture? So typically we don't treat those patients who are asymptomatic to avoid the resistance. Those who are symptomatic, we only treat them. Sometimes there are odd organisms like Proteus, Klebsiella, which are urease producing organisms, and we tend to treat them. Patients with the VUR, we tend to treat them to avoid the complications of pyelonephritis. If it is a recurring issue, you can consider prophylaxis for urinary tract infections, and it works very well for some kids. You can start with the oral antibiotics, small dose, nitrofurantoin, Bactrim, Keflex. If those medication doesn't work very well and there's not a success, intravesical gentamicin has also shown some benefit. Now, the pharmacotherapy in the forms of anticholinergics and the alpha blockers or prosympathomimetic medications, those patients who has decreased compliance, we can consider anticholinergic medication, those who has overactive detrusor activity, and those patients who has reduced outlet resistance or incontinence. Oxybutynin is very widely used and widely studied medication. It's available in different forms. It's available in syrup, pill forms. It's available in extended release forms. It has been given intravesical as well. What they do is basically crush the pill and instill in the bladder if the patient cannot tolerate oral medication because of the complication or side effects. It's also available in the as a cutaneous patch. You apply twice a week. It's available in different strength. Allergic reaction is one of the complications with the oxybutynin. Again, it's available in the gel form as well. There are other medications, and those are increasingly used. Solifenacin, Detrol, Myobatric is a recent one, which is a beta-3 agonist. It works very well. It works in combination. I did not, put them here because of the time constraint. Alpha-adrenergic medications, again, it depends what is the indications. If you are dealing with the incontinence and you want to achieve some bladder neck contractions, we can use pseudoephedrine, which is available as Sudafed, and that you can expect some bladder contractions and some continence, especially if the upper tract is safe. The sympatholytic medication or alpha blockers can be given if you want a bladder emptying. Typically, you can use either tamsulosin, or you can use the terazosin, which is available in 1 milligram formulation. So the other clinical scenario which we usually encounter is the a consultation for meningomyelocele who is recently born, and what to do with them. There are different clinical school of thoughts. Some intervene right away. They want to intervene right from the birth, and some things that we can defer and follow them. The way I was trained, I would say, is there a benefit? Yes, because that's how I was trained, and that's how we did, and we had a good experience with that. Some people may say no. We can follow them, and if there is a deterioration, they can jump in and can start intervention. But I would say literature support both. There are in favor of early intervention, and there are some against intervention, and there are some that says we can easily follow them, and if there's a deterioration, you can you can start interventions. So one of these study which was done by the Kogan, he compared 46 patients, those who were treated as an infant, and they started treating them right at infancy. And then there were 52 patients who were treated at age 4 when they were referred to them. It's not a true comparison, but it gives you some idea. And those patients who were intervened, the need for augmentation was only 11%. And those patients who were referred late and did not have any intervention done, the rate of augmentation was 27%. So that paper says that you can avoid bladder augmentation if you intervene early. And those who are in favor, they say the early intervention with CIC, antimuscarinic medications, improve urodynamics parameters, it decreases the rate of UTI, it decreases vesicular reflux, it prevents the upper urinary tract deteriorations, and the incidence of end-stage renal disease. We'll talk about this incidence of end-stage renal disease, a little bit controversial, whether it's truly prevented or not. And there are some factors which if you find them on urodynamic study, you can, excuse me for a second. So there are some factors, if you find them, especially if there's detrusor sphincter dyssynergia, if there's a high detrusor pressure, febrile UTIs, and vesicular reflux, they are a risk population, and early intervention is required in them. So in contrary, Hickman, he studied 283 patients and he followed for 9 years. Those patients were observed from birth. They did an ultrasound, urine culture, and creatinine, and they followed them 3 to 6 months. And they found that those patients can be followed. Urodynamic studies and VCG were obtained when there was when it was indicated clinically, or if there was radiological deterioration. And he found that the renal deterioration occurred only in 5% of this group, which is again similar to if you intervene early in life. The other interesting findings with Takeman found, although it's a 1994 study, that there was no relation of the urodynamics findings in relation to the renal deteriorations. And he found that the VUR in UTI was a main predominant risk factors for renal deteriorations. So typically, Botox, if pharmacotherapy fails, it has been increasingly used in US nowadays. It's less invasive. You can inject that Botox injection in the bladder through cystoscope. It decreases the activity of the detrusor muscles by blocking the release of acetylcholine. It's typically if you fail the medication, or if the patient cannot tolerate the anticholinergic medications. Typically, we use 200, 300 units or 5 milligram per kilogram body weight. A maximum of 300 units can be given at multiple sites in the bladder. The onset is very variable. The response is very variable. Sometimes you have to wait weeks to get the maximum benefit. And usually the effect lasts for 6 to 9 months. FDA does not approve to repeat the injections within 6 months, so you will have to wait for 6 months at least if you need to re-inject. I think that's all. I did not touch the interstream or the augmentation part. I think Mavish might have covered those topics. So in conclusion, bladder management is critical both for protection of kidneys and development or maintaining of the continence. Urodynamics are essential component of the understanding of the bladder and urethral functions to stratify risk. Early onset of medical therapy can improve bladder functions, help to achieve continence, and may decrease the likelihood of the bladder augmentation in future. Bladder and sphincters are dynamic in myelomeningocele, and you have to do a surveillance, and you have to do a repeat study in order to monitor the risk of bladder or kidney injury. Medical bladder management should be the initial choice, but surgical therapy may be necessary in some circumstances to prevent the kidney or to gain continence. Thank you, and I'm happy to answer any question. assume this is your last lecture of the day. So we still have time, but I would not let you stay here if there are no questions.
Dr. Zaheer, there are a few questions in the chat box if you can answer them.
Okay, let me see. So one of the questions was, is the Hinman and bladder or dysfunction elimination syndrome is the same or different entity? Overactive bladder syndrome is just detrusor overactivity, or it has associated spinal dysraphism. So very good questions. The recent classifications, they just all them put together in the daytime lower urinary tract symptoms. In the Hinman syndrome, it's a separate, it's a clinical entity where there is bladder bowel dysfunctions, and it's associated with behavioral issues. It has associated with neurological dysfunctions, not the anatomical. It has been associated with the sexual trauma as a childhood. So there are a lot of social issues which can be associated with Hinman syndromes. But again, those can be grouped together all in the same, one definitions. And your urodynamic study tells you how to how to classify them. In terms of management, it's again, it's the same if you have a neurogenic bladder or just a and how it behaves. Sometimes they may behave very worse, and they can deterioration can happen very rapidly in these cases as well. There may not be any spinal abnormality in these kids, but you have to rule out and make sure that there is no spinal abnormality in these kids. But typically with the Hinman syndrome, there is not. The other question is there any numerical range for bladder signs? Again, very good question. If you look at the if you look at the graph or the typical pattern of the bladder filling, the bladder pressure remains zero at most stage. It looks, you look at the curve of the graph actually and see if it is start rising, that's abnormal. If it rises, go back to zero or low pressure, that's normal. And usually safe bladder pressure are considered less than 30 centimeter of water. Again, someone said that please tell us about the management of nocturnal enuresis too. Sorry for the missing this part. I thought it's a completely separate entity. The nocturnal enuresis, I would say, if it is just an isolated nocturnal enuresis and there is no daytime lower urinary tract symptoms, the treatment is completely different. If it is associated with the daytime lower urinary tract symptoms, you have to treat those patients as a neurogenic bladder or bladder dysfunctions or daytime lower urinary tract symptoms. With the nocturnal enuresis, the work of the history examinations all are the same. You have to rule out all the neurological causes. I'll go very quickly through this because we may not have a lot of time. And the voiding diary tells you a lot about these patients. You check the urinalysis, make sure what is the specific gravity of the urine. The voiding diary will tell you if there is how much are the volumes in the nighttime, if the patient is has the concentrating ability or is the loss of diurnal variation in these kids.
Now, would you count all it?
You get at least, I think someone mic is open. So the voiding diary tells you a lot of informations. It tells you how much, what are the drinking habits, and sometimes it's an easy fix if you know that the patient is drinking at night time, and you will be surprised that sometimes that happens. I recently saw a patient who has this nocturnal enuresis since childhood. And the frequency was very variable. The mom said that he does not have any issue voiding when he's outside in hotel or camp, but when he's home, he leaks at night, and he passed large volume. And I asked him to fill a bladder diary, and I was surprised to see that he was drinking. Most of his water intake was at night time. He used to work in farm, and when he used to come home, he just can't try to overcome that dehydration, and he used to drink all water intake at night. So when you recommend treatment these kids, you tell them take your 2/3 of water intake, in the morning half, and then the 1/3 in later till by the evening, and restrict water intake. That's the first step. If in the voiding diary, if it shows you that there is a loss of diurnal variation, patient is making more urine, and especially if it's more than 1/3 of the urine output, then the desmopressin has a role. You can give 200 to 400 milligram a day, and you can monitor them. What is the response? The bells are, again, these are the non-invasive. There is no medication involved. Sometimes behavioral modifications, waking up kids at nighttime, make sure that they pee, and so those are the basic management, but make sure that you do all the workup first and desmopressin at the last. You have to be careful and mindful about the complication of the desmopressins. If you don't restrict water intake with desmopressin, it can lead to very severe hyponatremia, so I would say the first step would be to restrict the fluid intake by night, and that's the very important steps regarding the management of nocturnal enuresis. I'm just thinking if I missed anything regarding that. But if you have any question, you can just send me a text. Let's see if there are any more questions. Okay, is CIC practically not difficult for female child? Does a female patient always needs a conduit or abdominal wall or intermittent cath? It's not difficult for female child. Is CIC practically not difficult? Okay, so I don't think it's difficult. It's relatively easier. There is less chances of urethral injury in females. It's a short urethra. And they do very well. Sometimes you have to use, if the family members can do it, and when they become and they can do themselves, they can use a mirror to help find the urethral orifice and do it. Okay, I think I'm just going through the other questions, and at which times we are going to do augmentations. Okay, that's again a very good question. I did not touch that topic. But if there is a failure of the medical treatment, if there is a failure of the minimally invasive options, and the bladder is hostile, deterioration of renal functions, if you want to achieve continence, in those cases, yes, we go for the augmentation, cystoplasty. And role of prophylactic antibiotic in child with lower urinary tract dysfunctions. Again, not typically with the, there is no role of prophylactic antibiotics with lower urinary tract dysfunctions, but if you encounter recurrent urinary tract infections, and it's more complicated, then in those cases, yes, there is a role of prophylactic antibiotics. Especially like, it's a little bit, it's a controversial topic. Some people say that, with the VUR and the bladder dysfunction, yes, there definitely needs primary VUR, you don't need a prophylactic antibiotic. But children with the VUR and the bladder dysfunctions, there is a role of prophylactic antibiotics, and it helps in reducing the incidence of urinary tract infections. The last question, I think isn't it trickier to have augmentation in a child who has already developed early CKD? That's a very good question, and it's I would say it's the tricky part. I'm not sure what you are pointing out to, but if someone has a CKD, so make sure that you don't use colon. There is more absorption, there is more mucus formations. Ileum is a little bit better. There was a time when people used the stomach as a patch as a segment for the augmentations. It's no more used. There are more complications. Okay, so it means metabolic load. That's a good thing. So then when you do the augmentation in relation to the transplant, I think that's sometimes is like a kind of challenging thing to determine when we do it to avoid the metabolic complications. So if someone has a live donor, we can do the augmentations few weeks, 4 to 6 weeks prior to the planning of the renal transplantation. If there is no live donor and the patient is on waiting list for deceased donor, then in those cases you can do renal transplant first, and then the augmentation cystoplasty later. And meanwhile you have to manage the bladder conservatively. But again, sometimes it's challenging to do that. But typically, to avoid the CKD complication or metabolic complication with CKD, if you do the augmentation cystoplasty in those kids, their renal deterioration can progress rapidly. So you have to be mindful that in that regard as well. I hope I answered that question. Is there any other question or concern? You guys, if you have any question or concern, you can email me as well. Perfect. So if there is no more questions, I would say thank you so much. I was very excited to be a part of this lecture, and I would thank Dr. Hamad for inviting me. It's always a pleasure to see you guys.
Thank you so much, Dr. Zaheer, for your time.
My pleasure.
Thank
you.
I think we can conclude this.
Asking what is my email address. So it's simple. It's Zaheer_alam at you.
I will forward to them.
Maybe I can write it here. Okay, then if there is no question, I would leave. Thank you so much for your attention and listening.
Thank you, sir.